Hello student, welcome back to this channel. So this video is gonna be very important and very crucial in terms of your NEET PG preparation, and I want you to be focused with this video. So let's start with the ECG. So in this video we are going to cover few topics. The first topic we'll be covering is the area affected and the ECG changes. Then later we will be discussing some examples, and then we are going to study about the coronary circulation. So what are the variations in coronary circulation that we are going to get, and the area of coronary circulation that is affected, and the ECG changes that we are going to confirm. So what are the criteria of ST elevation in limb leads and in chest leads? For the limb leads, there must be ST elevation more than or equal to 1 mm in at least two contiguous limb lead. And in terms of chest lead, we have differentiated with the male women population. For men more than 40 years or equal to 40 years, it is more than or equal to 2 mm, and less than 40 years, it must be more than or equal to 2.5 mm, and for women, it must be more than or equal to 1.5 mm. So if this criteria is met, like limb and chest criteria and the elevation, then we will call it as a ST elevation. Right? Now, what do you mean by contiguous limb leads? So these are the leads looking at the same wall of heart, right? And what are those walls? For inferior, it is 2, 3, and AVF. For anterior, it is V1 to V4. For lateral, it's 1 AVL and V5, V6. For septal, it is V1 and V2. Now let's understand the area affected and the ECG changes, that is ST elevation, that we get on which lead. In this image, we are going to study only basic things about what are the areas that being affected and where the ST elevations that we are going to see. For the septal, we will be having ST elevation and V1 and V2. And how to remember this is that V1 and V2 both are placed very anteriorly and near the midline. So it is like the midline of heart. So we will be considering it as a V1 and V2 ST elevation in case of septal myocardial infarction. Now, how to remember about the anterior wall MI? Now understand, after V2, V3 and V4, these are placed very anterior to, like, it is in the front. So for anterior wall MI, we will be getting ST elevation in V3 and V4. And the reciprocal ST depression that we are going to see is in lead 2, 3 and AVF. Now what about if we combine this both septal and anterior wall MI? So anterior septal. For anteroseptal, it will be ST elevation in both of this, right? So V1 to V4, we are going to see ST elevation in case of anteroseptal MI. And the reciprocal we are going to get in 2, 3 and AVF. Now, what do you mean by lateral high and lateral low? We will be covering this lateral high and low in upcoming sessions, like in the coronary circulation, where we will be studying about what exactly high and low means, right? But as of now, just remember the lateral wall. So lateral wall is always supplied by left circumflex artery, right? So we are going to get the ST elevation in 1 and AVL. Now how to remember this? See, these are the augmented unipolar limb leads. So in this you can appreciate this is a AVL and this is a lead 1. So if you understand, this is the area that is seen by 1 and AVL is a lateral one. So lateral wall MI, there will be ST elevation in first and AVL, and in case of high lateral wall. What about the lateral low? So in this case, it's a ST elevation in V5 and V6. Now, how to remember inferior wall MI? In inferior wall MI, we will be getting ST elevation in 2, 3 and AVF, and the corresponding reciprocal ST depression we are going to get in first and AVL. Now, how to remember this thing? Understand, this is the second lead, this is the third lead, and this is the AVF. as we can see here, right? So it is like with the heart from below, that is from the inferior angle. So whenever there is an inferior wall MI, we will be getting ST elevation in 2, 3 and AVF. And the corresponding ST depression that we are going to get is 1 and AVL. Right? So this is about the inferior wall. Now what about posterior wall? So posterior wall MI can't be diagnosed with normal ECG. We have to put a posterior lead to diagnose the posterior wall MI. So in case of posterior leads, we will be getting ST elevation in V7 to V9 and the corresponding ST depression in V1 and V3 and tall R waves. Right? Now what about the right ventricle? Now most of the time right ventricle will always be associated with 2-3 AVF leads like inferior wall MI. So right ventricle is always associated with inferior wall MI. We will be discussing how this right ventricle is associated with the inferior wall MI, and we will be going to see the exact pathophysiology behind it. Right? So just bear with me. I will clear each and everything. Just follow this process. So right ventricle will be associated with the inferior wall MI, and we will be getting ST elevation into 3 AVF plus the right sided leads V3 and V4. Okay, I hope you are cleared up to this. Now let's take few examples of this ECG. So in this ECG, I think you can observe the ST elevation in 2, 3 and AVF, right? And the corresponding ST depression in 1 and AVL, right? So this is inferior wall MI, right? This is the second example. We can appreciate the ST elevation in V3, V4, V5 and V6. So this is the acute anterior lateral wall MI. Also we can appreciate ST depression in corresponding leads, that is second, third and AVF, right? So this is the anterolateral wall MI. Let's see this third example. You can clearly see that there is ST elevation in V1 and V2. So ST elevation in V1 and V2 considered as a septal wall MI. If this is associated with the ST elevation in V3 and V4, then what we will call it? We will call it as a septal anterior. Right? Now let's talk about this fourth ECG. So in this ECG, I think you can appreciate the ST elevation in second lead, ST elevation in third lead, and also the ST elevation in AVF. But in this case, we can say this ECG shows an inferior wall MI. But if you observe, you can see the V5 and V6, there is also ST elevation, right? So what do we call it as? We will be considering it as an inferolateral STEMI, right? So V5, V6 will be considered as a lateral wall, and 2-3 AVF will be considering as an inferior wall, right? What about the reciprocal ST depression? We can appreciate this ST depression in first lead and this AVL. So this is the inferolateral STEMI. Right? Now let's talk about the coronary circulation. Now the main coronary circulation is depend upon only two major arteries. The first one is left coronary artery and the second one is right coronary artery. Right? Now left coronary artery gives two branches. The first one is circumflex artery and the second one is anterior intraventricular artery. Right coronary artery plays important role in supplying blood to right ventricle with the help of right marginal artery and SA node through nodal artery and intraventricular artery in the posterior aspect of heart, that is a posterior intraventricular artery. So in the most of the cases there is a right dominant. What do you mean by right dominant? It means that posterior intraventricular artery is from the branch of RCA, right? And only 8 to 10% the posterior intraventricular artery is from LAD, right? And there may be the co-dominancy. Let's understand about the walls. So this is the cut section of heart, and you can see this is our anterior aspect and this is your posterior aspect. RCA will supply most of the blood to the SA node and AV node, including inferior wall of left ventricle and posterior one-third of intraventricular septum. We can say is the posterior interventricular septum, right? Most of the right ventricle is being supplied by this RCA, right? And in few times, the little bit part of the posterior aspect of left ventricle is also being supplied by right coronary artery. Okay, what about the LAD? Now LAD supplies the anterior wall of left ventricle, as you can see. Also the anterior two-third part of interventricular septum, right, and the apex of left ventricle as well. What about the LCX? That is left circumflex artery. Left circumflex artery provide blood supply to left atrium and lateral wall of left ventricle, as we can see here. Also there is a posterior wall of left ventricle that is in left dominant. It can be supplied by left circumflex artery. Like, so this was a basic coronary circulation that we must understand. Now we are going to learn about the individual arteries. The first one is RCA, that is right coronary artery. First one to understand is RCA, that is right coronary artery. Now RCA supplies blood to SA node, AV node, right atrium, then right ventricle, inferior wall, then posterior wall. So these are the areas that have been supplied by the RCA. Now RCA has three branches. The first branch is SA nodal branch, right? And the second one is atrial branch, and the third one is right marginal branch. Now these branches are very important to understand. Suppose SA nodal branch is compromised, that there is a occlusion which result in the compromise of SA nodal branch. Then what we will get? We will be getting bradycardia, right? Why do we get bradycardia? It may be due to the decreased blood supply to SA node, or there may be the increase in vagal stimulation. In atrial branch, if there is a compromise in atrial branch, what we will get? We can get atrial tachycardia, right? Also we can get atrial fibrillation. Now this right marginal branch is one of the most important branch in terms of MI. Now where does it supply? So right marginal branch supplies blood to right ventricle, right? And right ventricle plays very important role for preload. Now suppose if the right marginal branch is being compromised, what we will get? We will be getting right ventricular dysfunction, and this will lead to decrease in LV filling, right? So this will cause hypotension, and due to right ventricle dysfunction, there will be stasis of blood in right ventricle. So there will be increased JVP. So there is a triad of right ventricular MI, or right ventricular MI, and it is a hypotension, then raised GVP, and the third one is clear lung fills. So these are the clinical triad of right ventricular MI. Now there are two occlusions of RCA. The first one is a proximal RCA occlusion, right? What do you mean by proximal RCA occlusion? There is a occlusion before marginal artery. So what will happen in this case? In this case, we can get right ventricular myocardial infarction, right? Also we can get inferior wall MI. So this right ventricular myocardial infarction, that means it has a very poor prognosis. Now what about the distal RCA occlusion? Distal RCA occlusion means there is a occlusion after marginal artery, right? So there will be the sparing of right ventricle. Suppose this is your RCA, this is your marginal branch, and this is your distal branch. Suppose if there is occlusion at this point, then there will be infarction at RV as well as inferior wall, right? Suppose the occlusion is here, then RV will be spared and there will be only inferior wall MI. Right? To summarize, let's see proximal and distal. Here we can get right ventricular myocardial infarction, right? Also, we can get inferior wall MI, and there will be plus minus posterior wall MI. What about the distal RCA? There will be only two things: inferior wall MI, or there will be presence or absence of posterior wall MI. Now, in this scenario, we are considering so this scenario we are considering that posterior interventricular artery is apart from right coronary artery, right? That is a dominant one, around 80%. Now let's understand about the inferior wall MI in this scenario. See, inferior wall is supplied by posterior intraventricular artery, right? And in 80% of patient, this posterior intraventricular artery is from right coronary artery, right? But what if this posterior interventricular artery is from LCX? Because there are few patients, like around 10%, they have a posterior interventricular artery from LCX, right? So in this case, if the patient is having RCA occlusion, but the posterior interventricular artery is from LCX, then inferior wall MI is not the characteristic features of this RCA occlusion. Understand? Suppose you get a question in which they are saying that there is a RCA occlusion, right? And posterior interventricular artery is from LCX. So they will ask you which is not the characteristics wall MI in this particular condition. So in this, it will be inferior wall MI, right? Since it is been supplied by LCX, right? So RCA with non-dominant posterior interventricular artery, we will be getting only right ventricular MI or posterior wall MI, and inferior wall MI will be absent. Now, what is the ECG features that we can get? So inferior wall MI, as we studied, we can get ST elevation in 2, 3 AVF. In right ventricular, we are going to get in 2, 3 and AVF with V3 and V4. Posterior lead ST changes. What about the posterior wall? We will be getting 5 V7 to V9 in posterior wall leads, right? So these are the ECG changes that we can expect in this RCA occlusion. Now there is some clinical aspect that we need to understand about this inferior wall MI, is that inferior wall MI is associated with the right ventricular infraction, right? And in this case, it is having a hypotension, increased JVP, and clear lung fields. So in this case, this MI respond to fluid. So we need to avoid NTG in this particular wall MI, right? So this is the only MI in which we can give fluid to resuscitate in hypotension. Now the second blood vessel is left coronary artery. So left coronary artery have two branches. The first one is anterior descending branch of left artery, right? And the second one is LCX, that is left circumflex artery. Now left circumflex artery supplies blood to lateral wall. In case of occlusion of left circumflex artery, we will be getting lateral wall MI, and the leads in which we are going to get stimulation is first and AVF. Now this anterior descending branch is important. Suppose this is your anterior descending branch of left coronary artery. In this, there are few septal branches that goes straight to heart. And there are few diagonal branches that supplies the lateral wall. So what is the sequence of these branches? So the first, we will be getting septal branch that directly pierces heart and it supplies blood to septal wall. Then we will be getting D1. Then again we will be getting S2, and next D2, and then it's a straight LAD, that is a distal LAD. Suppose there is a occlusion at this point, then what will happen? There will be compromise S1, D1, S2, D2 and distal LAD. All of these branches will get compromised, right? So everything will be compromised. So it will be having a septal, anterior and lateral. So this is called high LAD, right? What if the occlusion is in between S1 and D2? What we will get? In this second case, there will be sparing of septum, right? So in this case, we will be getting anterior and lateral wall only, right? What if only distal LED is involved? For distal LED involved, we will be getting only anterior or apical wall MI, right? So depending upon the level of occlusion, we are getting a different areas of heart that has been affected, right? So if the ECG shows septal MI, that is V1, V2, anterior wall MI, that is V3, V4, and lateral wall MI, that is V5 and V6, then you can say there is a proximal LED occlusion, and this is a serious one. If you see the ECG showing there is only anterior wall and lateral wall MI, that is anterolateral, that is V3, V4, V5, V6, you can say there is a occlusion between S1 and S2. And if you only get the anterior wall MI, that is V3 and V4, then you can say there is a distal LED occlusion. So these are the levels of occlusion in LED. I hope you understand about this, both RCA and LED, and the levels at which we are gonna get these ECG changes and occlusion. So this was all about the ST elevations. Now let's understand what is the algorithm for STEMI. Let's say there is a patient that is presented to your ER and he is complaining of chest pain. Now with the history and your physical examination, you will divide this patient into three categories, whether it's a STEMI or whether it's an STEMI or it is an unstable angina. And according to that, you have to follow the particular algorithm, right? So for the initial assessment, there is a timeline that has been given by AHA, right? There is an American Heart Association which gives a timeline to assess patient initially, and the timeline for this initial assessment is 10 minutes, within 10 minutes. So you receive the patient and that patient is complaining of chest pain, which is a typical for the ACS, and you did ECG and it shows the ST elevations. So do you think that this patient needs a tropi? What do you think? So in case of STEMI, you don't need to measure tropi to diagnose it as a ACS, right? So you don't need to do tropi to diagnose ACS in case of STEMI only, right? But still, will you go for tropi? Yeah, you will go for the tropi. Why? Because it gives the prognosis. So the more the level of this tropi increase, there is a poor prognosis, right? So tropi we usually do for the prognosis. To go further, I would like you to understand two terminologies. The first one is the first medical contact. Now, what do you mean by first medical contact? So it is a first contact for patient by any EMS or nursing which are capable of diagnosing STEMI. So whenever you receive a call that this patient is having chest pain and your EMS team goes to that house and will get a first contact to that patient, that was the time 0, and we calculate our rest of the events from that time. So FMC is the first medical contact that has been done by any EMS or nursing staff. The second thing is PCI. Now what do you mean by PCI? PCI stands for percutaneous coronary intervention. Now what does it exactly mean? Understand, suppose this is your vessel, it is blocked by a thrombus. So to remove this thrombus, we have two options. The first one is the medical, that is we will give some medication to remove this thrombus, or the second thing is to go mechanically, in which we will insert a stent or balloon, and this balloon will inflate at this thrombus and it will clear the path. Now what do you think, which is more efficient? The mechanical one is more efficient than this medical one, right? So percutaneous coronary intervention is a procedure in which we will insert a wire to affected vessel and we will try to clear that area. So it is a gold standard procedure to treat STEMI, right? Now suppose you are working in a hospital where there is a facility of cath lab, right? So PCI is done in cath lab only, right? So suppose if you are working on a corporate hospital where there is a facility for the cath lab, and as soon as you receive this STEMI patient, you will activate your cath lab immediately and you will transfer that patient to cath lab for a mechanical reperfusion of culprit artery. Now suppose you are working in a remote area where there is a no cath lab and you receive a patient with the STEMI. Then what we will do? Then you will go for pharmaco-invasive strategy. What do you mean by pharmaco-invasive strategy? In this case, you will go for a medical reperfusion first, followed by this PCI, right? So for the facility in which there is no cath lab, we will go for a medical thrombolysis, and after that we will shift that patient where the cath lab is present. Understand? Now, what do you mean by door to needle time? So it is a time between patient presenting to your door to the start of thrombolysis. And AHA guideline has mentioned the specific timeline for this door to needle time, which is less than 30 minutes. So any patient presenting you within the 12 hours of symptoms, you can go for medical thrombolysis. So what are the agents that we can use for thrombolysis? So AHA has defined that tenecteplase is superior to other agents like streptokinase and alteplase. So tenecteplase is a much more efficient thrombolysing the patient. Right now, AHA has defined a particular criteria to thrombolize patient according to the age. So there is a age-based thrombolysis. Now, suppose if your patient is more than 75, then we will thrombolize with the half of the dose. Right now, we use tenecteplase as a 0.5 mg per kg bolus. But in case of patient with the age more than 75, we are going to use 0.25 mg per kg, right? So this thing has to be remembered. Also, if the patient is more than 75 years of age, then we have to skip our loading dose. So no loading dose of clopidogrel, right? Instead of loading dose, we will start with the clopidogrel 75 mg daily. So there is no loading dose. And routine, we can use unfractionated heparin or enoxaparin. For age less than 75 years, tenecteplase of full dose has to be given. We have to give aspirin for 325 mg. We also have to give clopidogrel 300 mg loading dose, and we have to use unfractionated heparin or enoxaparin. So the most important thing is to remember about age-based thrombolysis, and which is if the age is more than 75, you have to use half of the tenecteplase. We have to use only daily dose of clopidogrel. Don't use loading dose of clopidogrel only. Okay. And after thrombolysis, we need to transfer this patient to PCI center and continuous monitoring. Now there is one more thing to remember, that is the emergency rescue PCI. Now understand, the examiner will ask you a question in which he will ask that after thrombolysis, they will give you the reassessment of the patient, in which they will tell that there is a less than 50% of ST resolution and there is a persistent chest pain, and they might mention the arrhythmia or heart failure. So in this case, they will ask you the next step of management, and the next step of management is emergency rescue PCI and not the routine angiography. So if the thrombolysis is successful, then we go for angiography, and if the thrombolysis is failed, we go for emergency rescue PCI, right? Now, what are the criteria for successful thrombolysis? If there is a resolution of 50% of ST segments, right? If there is pain relief and there is a hemodynamic stability. So these are the three criteria in which we will decide whether this patient has been successfully thrombolyzed or failed thrombolyzed. According to that, we will take our next step, right? So what are the indication of rescue PCI? So assessment at 60 to 90 minutes. Now this timeline is also important because they will ask you what is the timeline for reassessment after thrombolysis. So 60 to 90 minutes is a time limit for reassessment. We will call thrombolysis as a failed thrombolysis if there is ST resolution less than 50% and there is a persistent chest pain or patient might be having in shock or arrhythmia or heart failure. So in this case, immediate rescue PCI has to be done, right? What do you mean by PCI? The same. We will insert a stent and we will clear the thrombus, right? Now, what is the advantage of tenecteplase? So tenecteplase is a single IV bolus, right? About this streptokinase and alteplase. So this agent has to be administered with the infusion pump and it will take a time, as well as there is an increasing risk for bleeding as well. Right? So tenecteplase is a single IV bolus dose and it has a better fibrin specificity. Right? The dose, as we discussed, it is a 0.5 mg per kg and more than 75 years, it is a half dose. So in exam, they might ask you about the calculation of tenecteplase. They will give you the age of patient as more than 75 or 80, and they will ask what is the dose for tenecteplase in this case. About the alteplase, we have to use a 15 mg bolus followed by infusion, and total max 100 mg can be given. About the streptokinase, it is 1.5 million in units IV over 30 to 60 minutes. Previously, we used to use this streptokinase and it was fairly good, and the chances of bleeding is increased in this agent. There are few chances for anaphylaxis as well, right? So nowadays we don't prefer this streptokinase, but still in few remote areas the doctors prefer this streptokinase because it has a better availability and the costing effect, right? Now what about the enoxaparin? So enoxaparin is a low molecular weight heparin, and there is a unfractionated heparin. Now unfractionated heparin is preferred agent in renal failure. Right? Now what is the mechanism of enoxaparin and heparin? So enoxaparin works with inhibition of XA inhibitor. Right? It majorly inhibits the XA and it also binds to antithrombin 3 and increase its activity so that it will decrease the thrombosis. On the other hand, unfractionated heparin will inhibit XA and 2A. Right? So this is used in renal failure more efficiently. And about the enoxaparin, it is a low molecular weight heparin. The dose for the enoxaparin is 30 mg IV bolus followed by 1 mg per kg subcutaneously over 12 hours. Right? About unfractionated heparin, there is a renal failure is one of the indication, and the dose is 60 unit per kg and maximum 4000, and followed by 12 unit per kg per hour infusion. The dose for this both drugs is not that much important in terms of NEET PG, but you need to understand what are the drugs that we use in this ACS. Let's talk about ticagrelor. So ticagrelor is a antiplatelet drug in which we give 180 mg loading dose and then 90 mg BD. So whenever the patient, if you plan for the PCI, if you plan for the urgent PCI, the drug of antiplatelet that we use is a ticagrelor. And if you are planning to thrombolyze patient, we prefer clopidogrel. What do you mean by this? So whenever the patient comes to you with the history of chest pain and you have categorized patient with the STEMI, so you will decide whether you have to give PCI or the thrombolysis, depending upon your facility, right? As soon as you decide the particular mode of revascularization, you will give the loading dose. Now, what are the drugs that you use for the loading dose? For the loading dose, we use aspirin, ticagrelor, and statin. So, whenever we are taking patient for PCI, we will prefer ticagrelor, and in case of thrombolysis, we will prefer clopidogrel. And this is also depending upon the age factor, right? So for thrombolysis, we will prefer clopidogrel, and for PCI, we will prefer ticagrelor, right? Now the next thing is about the tirofiban indication. Now tirofiban is a drug that is glycoprotein 2B3A inhibitor, and it is commonly used for the bailout PCI. Now what do you mean by bailout PCI? So whenever we go for PCI, there are a few patients which have a high burden for thrombus, or during PCI you come across a thrombus which is very hard to break. At this time we will use Tirofiban as a bailout PCI. So it is potent antiplatelet drug which will dissolve the thrombus, right? Next thing is about the NTG. It is used for the relieve chest pain, hypertension, and pulmonary edema, and the dose is 0.4 mg sublingual. Right? This drug has to be avoided in right ventricular MI and hypotension. Again, we use statins for plaque stabilization and to reduce recurrence of MI. Then the other drugs like AC inhibitors, which is a significant for prevention of remodeling and improve survival. So now there are the different mechanism of PCI that we can use in cath lab, and one of this is rotablation, and one is a DES implants, that is a drug-eluting stent. So you can appreciate in this image that there is a thrombus present in your arteries, and we will insert a wire which will cross this thrombus, and there is a stent that is present, and we will inflate this balloon which will deposit our stent in artery so that there is a further establishment of flow, right? Also there is a presence of a rotablation which works in case in which there are the high amount of calcification in arteries. In this case we will pass a probe through which there is a rotating machine, that is rotating micro machine, that will rotate around like 1,40,000 to 1,80,000 rpm, and it will ablate the calcified plaque, and this will create the revascularization of artery. So these are few methods to do PCI as well. So what are the major contraindications to fibrinolysis? Important contraindications includes intracranial hemorrhage, cerebrovascular malformation, and intracranial malignancy. Understand, in every hospital there is a checklist of this all contraindications, and we have to just put the tick mark whether it is present or not. So in this case of major contraindications, this ICH, cerebrovascular malformation, and intracranial malignancy is contraindicated. Now again, if there is a ischemic stroke within the previous 3 months but not within the last 3 years, be contraindication to fibrinolysis. Now why not the last 3 hours? Because we can thrombolize the stroke as well, right? If there is any symptoms and signs of aortic dissection, or if there is any active bleeding which includes peptic ulcer, or there is any hematemesis, right? So any internal active bleeding is a contraindication, or there is a significant closed head facial trauma in preceding 3 months, right? So these are the major contraindications. Now let's revise the timelines of STEMI checklist. As we know, ECG has to be done within the 10 minutes, and if the hospital is equipped with the cath lab, then we have to perform PCI within 120 minutes, right? The door to balloon time is less than 90 minutes, right? In some cases they can ask you wire crossing, so it is same like door to wire crossing or door to balloon time, right? Then first medical contact to device time should be less than 120 minutes. Now suppose you receive a patient with the STEMI and you are not able to perform PCI within a 120 minutes, then what we will do? We will go for thrombolysis, and door to needle time for this is less than 30 minutes. Right? After thrombolysis, we have to assess around 60 to 90 minutes to understand whether this thrombolysis has been worked or not. So the failure or successful thrombolysis is defined after 60 to 90 minutes of assessment. And if there is a less than 50% of ST resolution, that means we have failed the thrombolysis. And for failed thrombolysis, we go for immediate rescue PCI. Right? And if there is a successful thrombolysis, then what? Then we will go for angiography and PCI within a 2 to 24 hours. Right? So if there is a cardiogenic shock, there is an immediate revascularization regardless of the timeline. Right? There is also a timeline to start beta blocker, AC inhibitors, and ARB inhibitors, and it is 24 hours if no contraindication is there. Also, we have to continue dual antiplatelet therapy at least for 12 months after DES PCI, and uncomplicated STEMI can be discharged within 48 to 72 hours. So these are the basic timelines that we have to follow in STEMI checklist. The examiner will ask a direct question about this all timelines. So I want you to be thorough with this all timelines to correct your question in exam, right? Now let's understand the STEMI. What is the basic difference between STEMI and NSTEMI is that NSTEMI usually result from partial to subtotal coronary artery occlusion, while in STEMI we get the complete occlusion, and this results into the ST elevation. If there is any partial or subtotal coronary artery occlusion, then we get NSTEMI. So absence of ST elevation suggests of incomplete vessel occlusion, and there will be increased cardiac markers, right? So why don't we thrombolize this NSTEMI? Because there is a higher risk of intracranial hemorrhage, and this will outweigh the benefit of NSTEMI, right? If you try to thrombolize NSTEMI, then there is a chance of intracranial hemorrhage. So rather than benefiting to patient, it will worsen. It has chances to worsen the patient. That's why we don't go for thrombolysis in NSTEMI. So what we do in NSTEMI instead of thrombolysis is we go for antiplatelet and anticoagulants therapy. So we don't go for PCI in every NSTEMI. Rather than this, we will do PCI in few cases where there is a high risk of NSTEMIs. So this is an algorithm for NSTEMI in which we are going to give aspirin 325 mg, then ticagrelor, which is preferred, over clopidogrel. Also we give anticoagulants, that is unfractionated or enoxaparin, the dose we have discussed earlier, nitroglycerin, statins and beta blocker if no shocks, and oxygen if required. Now, there is a risk stratification with the help of few scores, that is a Gray score and TIMI score. The details for the Grace and TIMI score, I don't expect the question from this scoring, but we categorize patient with this into two parts. The first one is low intermediate risk and the other one is high risk STEMI. So for high risk STEMI, we will go for angiography. The timeline differs, but angiography is preferred. And in low to intermediate risk, we go for serial ECGs and repeat troponins. Right? So this was all about the STEMI and NSTEMI. I hope you got a decent idea about this STEMI and NSTEMI, and it will help you for your exam. Thanks for watching. See you on the next video. Thank you.